Good afternoon, everyone. I would like to welcome you to today's webinar featured and hosted by NSEED. I want to go over a few things to note before I begin. Participants will be muted upon entry and videos turned off. For technical assistance, please use the chat box. Third, you will receive an email approximately 1 month from today requesting feedback and impact on today's presentation. Lastly, we ask that you visit our training center at www.ncedas.org/training to view other training opportunities that NSEED offers. As a reminder, we will have a 10-minute question and answer segment at the end of this presentation. Any unanswered questions will be sent to you via email 1 week from today's presentation date. A copy of today's webinar presentation will be sent out immediately after the webinar has ended with an evaluation that we ask for you to complete. I'll now go ahead and introduce today's speaker for today's webinar titled Refeeding the Adult and Adolescent Eating Disorder Patient. Today's speaker is Ms. Anna Lutz, a registered dietitian at Lutz, Alexander & Associates Nutrition Therapy in Raleigh, North Carolina. She specializes in eating disorders and pediatric family nutrition. Anna received her Bachelor of Science degree in psychology from Duke University and Master of Public Health and Nutrition from the University of North Carolina at Chapel Hill. She's a certified eating disorders registered dietitian and an approved supervisor, both through the International Association of Eating Disorder Professionals, IADEP, and also previously worked at Children's National Medical Center in Washington, D.C. and Duke University Student Health, treating individuals with eating disorders. She has completed extensive training through the Embodied Recovery Institute and strives to provide her clients trauma and somatically informed care. Anna is a national speaker and delivers workshops and presentations on eating disorders, weight-inclusive healthcare, and childhood feeding. She also writes and talks about nutrition and family feeding, free of diet culture, on her blog, Sunny Side Up Nutrition, and her podcast, Sunny Side Up Nutrition Podcast. I'll now turn things over to Ms. Anna Lutz.
Thank you so much, Lachelle. I really appreciate the introduction, and I'm thrilled to be here today for this presentation. And we're just going to we're going to jump in. So we're talking about refeeding and the adult and adolescent client. And I think we've covered the introduction. I'm thrilled to be here. And I wanted to highlight that I'm an outpatient clinician. I've always been an outpatient clinician. So the presentation today is going to focus on outpatient nutrition rehabilitation and when to refer to a higher level of care. Our objectives today, we are going to be at the end be able to list 3 medical risks of malnutrition, regardless of body size, in a patient with an eating disorder. We'll be able to define refeeding syndrome and assess for refeeding syndrome risk, and explain how to determine expected body weight in the treatment of a patient with an eating disorder. And so our outline today is I'm going to briefly cover the importance of screening for eating disorders in your practice, the risks of malnutrition. We're going to go into refeeding syndrome, and finally close the webinar discussing expected body weight. And we'll have time at the end for questions. So, I always think it's important to talk about why it's important to be looking for eating disorders in our practices. We know that eating disorders are unfortunately deadly. They're the second highest, they have the second highest mortality rate of all mental illnesses. And 1 in 5 people diagnosed with anorexia nervosa die by suicide. Pre-pandemic, eating disorder rates had doubled. So you can see in comparing 2000 to 2006, that time period compared to 2003 to 2018, we had seen this significant increase in eating disorder rates worldwide. And OSFED, other specified feeding and eating disorder, is the most prevalent followed by binge eating disorder, bulimia nervosa, and anorexia nervosa. So that's how things were in 2018. And then since then, eating disorders in the pandemic, we all know, and you've probably heard from news media, eating disorders have been in the news quite a bit lately, that eating disorder rates have doubled again, and probably more, because these studies are showing hospital admission rates. One being hospital admission rates for eating disorders, and the other study showing emergency department visits related to eating disorders. And we know that eating disorders do not discriminate. They affect people of all races, ages, socioeconomic backgrounds, all genders, all body types and sizes, and all sexual orientations. Our field has a history of only focusing on females, on white females. And so, but we know that eating disorders affect all people. Unfortunately, people of color are 2 times less likely to be diagnosed with an eating disorder and 1.5 less likely to receive treatment. And so it's something that our field hopefully is working on and has a lot of work to do. People that are transgender have an increased risk of a significant increased risk of developing an eating disorder. And also there are increased rates of eating disorders in sexual minority youth. And so I wanted to point out NSEED's new screening tool, and the website is there on your screen, where in a primary care practice can pull up the screening tool and you can screen a patient for an eating disorder right there. It's specifically for adults. And so if you work with adolescents, I cited a study, and the resources are at the end of my slides, but also, assessing for dieting history in an adolescent. Any kind of dieting is a significant risk for developing an eating disorder. Body image dissatisfaction, experiences with weight stigma, any changes in eating and exercise patterns. And that's what I think we really saw in 2020 with all the changes that we all experienced. Psychosocial development, how's that going for the adolescent? Is there amenorrhea for someone who should be menstruating? And there's other training specifically focused on screening in the NSEED webinar library. I did a webinar a year ago that part of it was focused on screening adolescents. And so if that's something that you're interested in, I encourage you to seek out training there for screening. I also want to kind of point out that eating disorders can show up in anyone's office, that so often, the entry point into eating disorder treatment might be my office as a registered dietitian, and I'm doing an assessment, and then I may be referring to the medical provider and the psychotherapist, or the entryway may be through the medical provider. Someone comes with certain medical complications, and then the medical provider is doing their assessment and referring to the psychotherapist or registered dietitian. Or lastly, someone may feel more comfortable presenting to a psychotherapist, and then the psychotherapist may assess that there's an eating disorder and referring on to the medical provider and registered dietitian. And so the entry point can be anywhere. And that kind of forming that team as a minimum of these 3 providers is important. So malnutrition and its risks. I wanted to talk about just basic definitions. So malnutrition is the lack of proper nutrition, and that could be on many different levels. Today, we're going to talk more about severe malnutrition. Starvation is specifically severe deficiency in caloric energy. And then I wanted to differentiate between refeeding syndrome and what some people may call refeeding, or the more preferred term of nutrition rehabilitation. And so refeeding syndrome, which we're going to get into specifically today, is a range of metabolic and electrolyte alterations occurring as a result of reintroduction of food, of calories. And it could be food, it could be enteral nutrition or parenteral nutrition after there's been a decrease or absence of caloric intake. Refeeding or nutrition rehabilitation is that reintroduction. So someone may be going through the refeeding process, the nutrition rehabilitation process, but they don't have refeeding syndrome. And so I wanted to kind of, we're going to be talking about actually all of these things today, but I wanted to make sure to differentiate between refeeding syndrome and this process of nutrition rehabilitation. So what do we know about starvation? I bet many people on this webinar have heard of the Minnesota starvation study. And if you haven't, I encourage you to look it up. And there's very interesting articles about it. But this study involved 36 male conscientious objectors, and who was put on a semi-starvation diet. They were put on about a 1,500 calorie diet versus their needs of around 3,000. And all of these, the studies really showed the impact of starvation. These men started showing behaviors that we think of as specific behaviors of an eating disorder. So focusing on food, changing, cutting up food in small pieces, an increased focus on body and body image. And so we really point to this as a lot of the behaviors that we think of as eating disorder behaviors are actual behaviors of starvation. And that's why the nutrition rehabilitation process is so important, because without that, these behaviors will continue. It's our body's way of trying to stay alive. The first kind of noted experience with refeeding syndrome was first described after World War II, involving prisoners of war, concentration camp survivors, and victims of famine. So that was the first time refeeding syndrome was described. This is not an exhaustive list, but malnutrition affects all of our systems. It affects us all over our body. Specifically with our cardiovascular system, we see clients who may present with bradycardia, orthostatic instability, congestive heart failure. You can read the slides here, but I wanted to kind of highlight the psychological piece of anxiety, depression, hypervigilance, body image distress, and suicide. These are specific risks that are associated with malnutrition and not just eating disorders. So again, making sure someone is fully nourished, fully weight restored, which will be the last part of our webinar today, is important to reduce these risks. So I wanted to point out, and this will come up several times today, what our field calls anorexia nervosa versus, and I put it in quotes, atypical anorexia. And my personal opinion is I don't love that term because it's not fitting, because it is actually far more typical than anorexia nervosa. So the DSM-5, part of the criteria for anorexia nervosa, has this criteria of low weight. Now there's some, you can interpret it how you'd like, but it says in the low weight in the context of the age, sex, developmental trajectory, and physical health. So less than minimally, quote, normal or expected. And so when we see someone who is experiencing malnutrition, but they're not formally, quote, underweight, oftentimes they're diagnosed with this atypical anorexia, but their studies show that these individuals are just as physiologically, medically ill, and they have the same risks if they were at what we call a low weight status. And so I think this is an important piece. And that what we know is we need to look more at weight suppression, which is the comparison of current weight versus highest weight. And that can really be predicted. The greater weight suppression, the greater the difference between highest weight and current weight, can really be predictive of medical complications, regardless of where that current weight is in relation to, kind of standards of what's considered underweight. Again, we'll talk more about that, but I think that's an important piece as we're thinking through these individuals that are severely malnourished, that severe malnutrition can happen at any weight. So refeeding syndrome, the next several slides are going to be specifically about what it is, because we've all heard about it. And so sometimes it's good to stop and think, okay, what is refeeding syndrome? So to think about in times of nourishment, our body can really easily access energy stores, can use energy stores. We're putting micronutrients into storage as needed. We can access them. And there's this, we're in more of a catabolic state. In a building state. In times of malnutrition, we can efficiently use those available energy stores. Our body says, okay, there's not enough food here. We need to use those energy stores that are available to us, whether that's mobilizing fat or that's mobilizing glucose from our storage form of glucose, mobilizing protein. It's an easy kind of back and forth for survival. But in times of severe malnutrition, what starts to happen is that our vitamins and electrolytes become more depleted. And our electrolyte depletion can be exacerbated by diarrhea, vomiting, gastric drainage, diuretic use, which we see with a lot of our clients. And so we've gone from having malnutrition where we can kind of access what we need to survive to things being very, very depleted. And so today we're going to talk a lot about the Aspen guidelines for refeeding risk. And this is their proposed diagnostic criteria from the study of 2020. I'm going to go back a slide. This study that's cited here is those Aspen guidelines. And so when we see a decrease in any one of these electrolytes, phosphorus, potassium, or magnesium by 10 to 20%, and you can kind of see mild versus moderate versus more severe, or organ dysfunction, or due to thiamine deficiency, which would be severe, is that kind of everything after the or. And this would occur within 5 days of initiating nutrition. And so what I want to remember is that the Aspen is the Parenteral and Enteral Nutrition Society. And so a lot of they're looking a little bit more from an inpatient hospital standpoint. But regardless, this is an important definition of what is refeeding syndrome. So why does it happen? So when we introduce nutrition after severe malnutrition, blood glucose increases, right? We start to eat more, our blood glucose increases. Therefore, our insulin level increases because insulin's job is to help us utilize the glucose in our blood. As insulin increases, part of what happens is that phosphorus and potassium goes into our cells. And so what we see is that because there's already we're already depleted at severe malnutrition, this influx into the cells can drop to a fatal level. And that's, of course, what we want to avoid. So phosphorus, we're going to take each electrolyte one by one. Phosphorus is a vital component of ATP, which is our storage form of energy in humans. During severe malnutrition, our phosphate stores are used to produce ATP so that our bodies can keep going. So we're using up our phosphate stores to produce ATP. Phosphate depletion, which would happen during severe malnutrition, can lead to muscle dysfunction and respiratory failure. Low serum phosphorus levels can lead to cardiac arrhythmias, and phosphorus depletion can lead to tissue hypoxia. So when we start to eat, phosphorus can be kind of driven into the cells. Now, potassium, as insulin increases, it stimulates this sodium potassium ATPase. And so what we see is that enzyme that stimulates the potassium going into the cells and sodium going out of the cells. And so again, with the potassium going in, it can be a severe risk. And you can kind of see on the screen the risks of hypokalemia, which would be low potassium. And then magnesium, we don't fully understand magnesium's role in refeeding syndrome. Hypomagnesia impairs potassium reuptake in our nephrons. So there may be that might be the kind of association. So it may lead to excess losses. Hypomagnesium also impairs cellular transport of potassium. So low magnesium does low serum magnesium levels is a risk for refeeding syndrome. We also need to be looking at thiamine. Thiamine deficiency is also seen in refeeding syndrome. The demand for thiamine increases during refeeding. And so the cofactor for glucose-dependent metabolic pathway, thiamine is a cofactor for metabolic pathways. And so there's an increased demand of thiamine when during severe malnutrition, our thiamine levels are depleted. And so often thiamine is supplemented, and we'll get to that in a bit. So who's at risk? So, today we're mostly talking about individuals with eating disorders, but looking at the Aspen guidelines, other people are at risk for refeeding syndrome. And you can kind of see all the different individuals that we need to be on the lookout who may be at risk for refeeding syndrome. Today, we're going to be focusing on people with eating disorders. So to kind of summarize, refeeding starts with the reintroduction of nutrition. This increases our glucose load, just the act of increased nutrition, whether it's food or enteral nutrition or parenteral nutrition. There's an increase in insulin, and we move to an anabolic state. So we're shifting back to carbohydrate metabolism and protein synthesis. So we're going from this kind of catabolic state to a more anabolic state. And so what happens is there's this increase in cellular uptake of potassium into the cells, magnesium, and phosphate. And this increase of the anabolic demands depletes our stores that are already low. We also know that this deficiency can hinder the production of ATP. And so we have this impaired production and impaired utilization of energy that can happen. And so we want to go low and slow with nutrition to avoid this for the individuals that are at risk. So we need to be assessing for refeeding syndrome. The next several slides have a lot of words on it, but I wanted to, instead of just say, go look at the Aspen guidelines, I wanted you to have them here. For adults, the guidelines for assessing risk, they have two criteria. They have moderate and severe. So the next slide has severe risk on there. And so you can kind of see, looking at BMI, looking at weight loss, caloric intake, abnormal pre-feeding, phos, potassium, and magnesium. And so that'll, getting individuals initial labs as part of their medical assessment, I think is a really important piece. So we know where these levels are pre-feeding, pre-nutrition rehabilitation. Assessing subcutaneous fat, muscle mass, which may be hard to assess if it's not a patient long-term. And then looking at, are there other comorbidities that might put them at risk? So if an individual falls into two of these categories, they're considered moderate risk. And then for severe risk, if they have even one of these categories. So I do want to point out that BMI and is just one of these categories on either slide. And so again, that kind of supports that it's not just the individual that is at a very low weight that is at risk for refeeding. We want to be looking at all of these and do our patients, are they at risk for refeeding? The Aspen guidelines are separate for pediatric patients. And so for pediatric patients, because we're so, their caloric needs are different. They're in a growth, they're in that anabolic stage all the time. We want them to be gaining and growing and building new bone. The Aspen guidelines breaks it up into mild, moderate, and severe risk for refeeding syndrome. So this first slide is, you're at mild risk if you meet any three of these criteria. Something I want to point out is for the weight loss for the pediatric client, this is a % of expected weight gain. So if if a pediatric patient loses weight, they've already ticked off one of these risk factors that pediatric patients should not be losing weight. And so you can kind of see that the first one is a Z-score, so a change from their baseline if they are well below the third percentile on their weight for length or BMI for age Z-score growth chart. You can kind of see the others. Moderate risk would be any two of these. And so something I haven't kind of pointed out on these slides is energy intake. So we're looking for low energy intake for 5 to 7 consecutive days. Mild risk was 3 to 5 days, and severe risk would be more than 7 days. So it's interesting to kind of compare these, but this last one, the severe risk for pediatric patients, is one of these criteria is needed to be considered at risk. And so eating less than 75% of estimated needs for more than 7 days is considered at severe risk for the pediatric patient. So I wanted to also, offer what, in that initial medical assessment in the treatment of an eating disorder, what labs to include, what other things to consider as you're assessing the risk for refeeding syndrome. And so you can see the labs there. Something I wanted to point out was under additional serum tests is prealbumin. There's a study by Mailer and Gaudiani that shows that low prealbumin is predictive of medical complications in individuals with severe malnutrition. And so kind of getting that as part of that assessment is important. Also, orthostatic blood pressure, getting an individual's heart rate. I can't tell you how many of my clients have been told by a medical provider that their low heart rate is due to them being an athlete, being a runner. And so rather than from malnutrition. And so really assessing out, is this a malnourished heart? Is that why it's low? Or is it a conditioned heart? And the difference, and this is something I've learned from Dr. Gaudiani's presentations and work, is comparing a heart rate at rest versus walking down the hall. And a conditioned heart, a runner's heart, when they walk down the hall is not going to go up. It's not going to go up, but a malnourished heart, it will. So kind of doing that simple test. An EKG and a DEXA scan are often recommended for as part of that initial medical assessment in eating disorder treatment. And you can kind of see that the DEXA scan is recommended for 3 months of amenorrhea or 6 months of significant weight loss. And you can kind of read more about it in both of these books that I've cited at the bottom. So I wanted to point out that Aspen's recommendations for the initiation of calories, really a lot of it would need to be done in a hospital setting. And so I've highlighted that for the moderate to high risk of refeeding with low electrolyte levels, you need to hold initiation or increase of calories until electrolytes have been supplemented or normalized. And that's usually best done in a hospital setting, the supplementing low electrolytes. It's recommended to monitor every 12 hours for the first 3 days in high risk patients. So this is the recommendations for initiation for electrolytes. And this is for monitoring for someone who's at risk for refeeding, recommending vital signs every 4 hours for the first 24 hours after initiation. And so, something to consider when we're assessing the patient, assessing what they need. So when we have a patient come to us and we've assessed that they have severe malnutrition, we want to assess risk for refeeding syndrome. And to kind of think about, is this person chronically malnourished? Are they severely underweight? Is a piece of it, not always. And a big one is, this should say, or any of these, have they not eaten for 7 to 10 days? These are big red flags that this person needs a further assessment for refeeding syndrome, and they probably meet criteria. You want to obtain electrolyte serum levels prior to nutrition rehabilitation. That's an important piece of this, is to really obtain those levels. So if you do this assessment and you think you have determined that your client is at risk for refeeding, use the Aspen recommendations for initiation and use the APA level care guidelines to determine, is this someone that we can do nutrition rehabilitation in the outpatient setting, or does this person at a higher risk, a moderate to higher risk, that we need to start nutrition rehabilitation in a higher level of care. Medical stability is for the APA level of care guidelines, the APA eating disorder level of care guidelines, that really medical stability is important for outpatient level of care. If you determine this person's not at risk for refeeding syndrome, or maybe a lower risk, and you with the team has decided that to establish outpatient level of care, the question is, okay, what is the monitoring going to look like? Does this person need daily labs, every other day? How often are they going to see the medical provider as part of their outpatient team? And I wanted to make a note about family-based treatment. We know that when treating the child or adolescent, evidence-based care is utilizing family-based treatment, which is really putting the parents in charge of the nutrition rehabilitation process. And so sometimes that can feel at odds with refeeding risk, because it's, the recommendation is to keep the child at home. And so it's, again, you're really assessing the whole patient, the whole situation. Of course, we want to, first priority is that the patient is safe. And so if someone's at severe risk, they, need to be where they are safe. But sometimes it's assessing how can we do this safely on an outpatient level of care, so that family-based treatment can be done. So nutrition rehabilitation in the outpatient setting, the MD or PA, that should say medical provider, would correct electrolyte abnormalities if there are, and that's best done inpatient. You want to obtain serum electrolyte levels every day or every other day. For this was someone who may be at some risk for refeeding, and you've determined that they're going to be in the outpatient setting. We increase intake by about 300 to 400 calories every 3 to 4 days. So that's the lower introduction, so that the body, one of the big risks of refeeding syndrome is refeeding too quickly. So we want to keep it lower and slower. There's different evidence in research about inpatient care, where an individual can be more monitored. But if the determination is that the patient needs to be in outpatient care, we're going to stick to the 300 to 400 calories every 3 to 4 days. And if I'm working with a parent who's doing the refeeding or the nutrition rehabilitation with their child, I may be giving them a meal plan for Monday, and then I say, on Wednesday or Thursday, this is how you're going to bump it up. So we're trying to bump it up quickly, but not too quickly, and they kind of have stepwise. And in the outpatient level of care, we're looking for a 1 to 2 pound per week weight restoration goal, if weight restoration is needed, if that's what's determined, especially in a pediatric or adolescent patient. And so that's kind of our goal. And that oftentimes individuals who have experienced severe malnutrition need upwards of 4,000 calories to restore their weight. And that's really because of the increase of needs of the body to restore, heal. And so it can be a challenge in outpatient, but it certainly can be done. And the labs, of course, are important for ongoing medical monitoring, and also looking for tachycardia, edema, which can be signs of refeeding syndrome. So we need to be, for someone who we think could be at risk, really continuing close medical monitoring. As the dietitian, I'm really helping the client with a balance of protein, carbohydrates, and fat. If it's all carbohydrates, that would be more of an insulin increase, which could be a higher risk for refeeding syndrome, because what we talked about insulin playing that important role of driving the electrolytes into the cells. We want the food to be tolerable to the individual. So we're really looking for that balance of protein, carbohydrates, and fat. You may consider a lower sodium diet because of that insulin increases kidneys reabsorption of sodium. So sometimes we see that there's an individual experiences edema because of this. We wouldn't want that to limit the patient. I mean, fed is best. So we really wouldn't want to put strict guidelines about lower sodium if that is going to inhibit an individual to increase their caloric intake to that goal of 300 to 400 calories every 3 to 4 days. But it's something to absolutely consider and decide for this individual if that's appropriate. A risk of malnutrition at any body size is delayed gastric emptying or gastroparesis. So we may be looking at how can we make meals more dense, lower volume. So if someone's eating lots of salads, lots of fruits and vegetables, that's only going to kind of slow down the emptying time of the stomach more, and make you feel fuller, right? And so we really, if we're trying to get working towards that to meet their needs for nutrition rehabilitation, oftentimes we're trying to work with how can we condense these meals. The medical provider may consider a bowel regimen with fiber supplements and fluids if there's lots of constipation, delayed gastric emptying. That's something I usually let the medical provider handle. And oftentimes using liquid supplements is what's needed to get to the amount of calories that the client needs. And with these clients, we're usually recommending a multivitamin. And for the severely malnourished patient, a thiamine supplement, and that's usually 100 milligrams of thiamine per day for the adult. So I just wanted to do a quick case vignette to kind of give you an idea of what this might look like. So this is Kathy, an 11-year-old, 10-month-old white female who her mother presented with concerns of this client had an eating disorder. She had refused meals and weight loss for a few months. The patient denied trying to lose weight. And mom presented to the RD and had already started the refeeding process. She had researched how to help, and she had started, saying this is what you need to eat. And what I remember is she was buying her child some special baked goods from a bakery. And so a higher carbohydrate refeeding diet. And this was the child's growth charts at the initial visit. And so you can see, if you look on the left is the weight for age chart. On the right is the stature for age chart. So I'm looking at the weight for age chart, and you can see that drop between 11 and 10 months is where that last dot is. So she lost weight. If you just looked at that one plot point at 11 years, 10 months, I don't think anyone would have been concerned because it's within her range of variability. But it's that drop that's so concerning, and it's the slope of that drop that it's so steep that's so concerning. Looking over at the height curve, she's kind of plotted pretty predictably on the height curve. I often don't use BMI, but I'll get into that a little bit more with expected body weight, but you can see that drastic drop because of that weight loss. And so her current weight was 87.6 pounds. There had been about a 5-pound weight loss in 3 months. We'd expect her to be about 96 pounds looking at her growth history. So 5 pounds may not sound like a lot of weight loss to some people. It's really, she's down 9+ pounds. And so because children are always gaining and growing. So looking at this, she was 91% of her expected body weight. I put that there, getting a little ahead of us, but when someone's less than 80% of their expected body weight, that's when we start to think about residential level of care. So just looking at that may not be alarming, but it's the sharp rate of weight loss, and it's the fact that it's a child that has lost weight instead of gained weight. And so mom was doing a great job, already started the refeeding process. The child got labs the next day. But I want to show you this. If we just looked at this pediatric severe risk and we go through for this patient, for Kathy, what we know is there's been weight loss. So she hasn't gained her expected, and there has been, she's been eating less than 75% of her expected needs for more than 7 days. The rest are not known at that initial assessment. We didn't know her pre-feeding. Just mom came to that first visit, kind of following family-based treatment. So I recommended that I referred her to an eating disorder therapist, and I referred her back to her pediatrician for a medical assessment, and that's where the labs were done. And those initial labs did show low phosphorus, and then her liver enzymes were high, showing malnutrition. And so this person was stabilized at a residential level of care, inpatient level of care, before coming back out to continue family-based treatment. All right, so we're going to move into determining expected body weight. So there's lots of terms that are thrown around. So I always like to kind of start off with defining terms, like I did in the refeeding section of the talk. But ideal body weight is this very defined term in the dietetics field. For children, it might be 50th percentile weight for age, regardless of if a child was tracking along the 75th percentile or the 25th percentile. Some treatment facilities may say ideal body weight's 50%. That's the weight that we're kind of looking at, or 50th percentile BMI for age. Or it might be that for an adult, the Ham-Lee calculation, which you may know of, 100 pounds for 5 feet, 5 pounds for each inch after that. It's very kind of one size fits all. But what we know in eating disorder treatment is that we're all different, and genetically our body sizes are different. And so some people use the term expected body weight, which would be the body weight we would expect if the individual didn't have an eating disorder, or the treatment goal weight, though, is one factor of recovery, maybe get an estimated goal weight, or biological appropriate weight, I think is a great term. Like biologically, where are we guessing that this patient may be if they don't have their eating disorder? And so, and it takes in all of these factors. It takes in historical weight and height, growth trajectory, pubertal stage, menstrual history, energy intake and expenditure, extent the client is malnourished, and weight suppression. And so you're going to see some studies in a minute of why this is important, but that's what we're going to be talking about, is this right-hand side. So the determination of expected body weight in treatment is the role of the physician or medical provider and or registered dietitian. We might be working in conjunction with each other. It may be that if the registered dietitian is a eating disorder expert, they may be determining it, or vice versa. And there's no gold standard, is the truth. There's no gold standard of this is the one way to determine expected body weight or treatment rate. But I want to point out that there's so many studies that are, looking at population groups of patients. And sometimes ideal body weight is used in this research because it's set, it's easy to study, 50th percentile, kind of can cover a lot of people right in the middle. But the work that I do and the work that I imagine many of you do who are on this webinar, we're doing individualized care. So we need to think about this patient, what's going on with this patient, what's going to work best for this patient, what does health look like for this patient if that's their goal. So we know the research shows that evidence that even a small change in weight, as little as 5 pounds, can be the difference between having periods and not for the person that is supposed to be having periods. Evidence suggests that expected body weight or treatment goal weight may need to be set a little higher for menstruation to resume. And I touched on weight suppression earlier, but it's that difference between current weight and highest weight. And this needs to be factored into determining a treatment goal weight. That we know that higher weight suppression, so a bigger difference between current weight and highest weight, is associated with more severe eating disorder behaviors. And that higher weight suppression shows less improvement in symptomatology. So it's a risk factor. We want to be closing that to decrease someone's risk of eating disorder behavior or relapse. So if you're working with a child or an adolescent, the first thing I do is I look at their historical growth history. Growth charts are not perfect. They just give us a clue into what might have been going on before the eating disorder. The truth is everyone grows differently. And so you've got to, use it as information, but not the be all end all. Marking life events along the x-axis can be really helpful of, when did the patient start their period if they have, maybe there was a significant life event, when did the eating disorder start, to try to start to interpret the growth chart. Then I look over on the height for age. So that I usually do that on the weight for age chart. Look over on the height for age chart. Has there been a big cross in percentile of height for age? Has someone always been tracking between the 25th and 50th percentile height for age? Or were they at the 25th and now they're up at the 75th percentile? If someone has an earlier puberty compared to average, which average is about for menarche is about 13 for females, then if their puberty is early, then we often see them cross percentile lines on the height for age curve because their growth spurt is earlier than the population that was used to develop the growth curves. So that's an important piece of it. And if we cross percentiles in height, then most likely we're probably also crossing our percentile in weight, the weight for age chart. So we want to estimate expected body weight as a return to growth trajectory using weight for age. And with a pediatric client, we want to be determining it at 6 months from now. So if I'm working with a client that's 11, I'm going to be determining their expected body weight at 11 and a half, because it may take that long. We want to be kind of ahead of the 8 ball on this and not be always trying to catch up. We want to establish treatment goal weight as a minimum. I really recommend doing a minimum or a range, but let's kind of thinking, it looks like for health, to establish health, we need to be at least above this weight, and then reassess every 3 to 6 months for the pediatric client. For adults, we may or may not have growth curves, but we're assessing medical and weight history. If you can find growth charts, they can be really helpful. So if you have a 20-something-year-old or someone who has access to their growth charts, that can really shed some light on growth history. They might remember their weight in high school. You might be able to get some points. Has there been a pregnancy history? What is this client's dieting history over the years? How does that impact their weight history? For people that are supposed to be menstruating, have menstrual cycles stopped? And at what weight did they stop? And is there weight suppression, and how big is that? And so we want to continue to reassess as we're working with the client. But it's honestly, with an adult, it's a educated guess, and then we're making a lot of reassessment. But I really caution us all about setting goal weights too low. We're all affected by fat phobia and diet culture, and we know that if research shows that if goal weights are set too low, it can really impact the patient's recovery or risk for relapse. So as little as 2.2 kilograms have been shown to drastically reduce a person's risk of relapse. A rate of weight gain has been shown to reduce risk of weight loss. So really someone restoring their weight quickly. And that we know that negative energy balance, so dieting, restricting calories, is a contributor to eating disorder. That's what we learned from the Minnesota starvation studies. And so if someone's weight is kept too low, they're at that negative energy balance. then they can't recover from their eating disorder. So what if growth and weight history isn't available? Certainly that happens all the time. And so, we're trying to determine, are there any plot points available? What is the pre-morbid weight? Are there some sick visits from a doctor's office? Are there weights in a baby book? Or is there anything we can kind of determine? And we might defer expected body weight. If we don't have any weight history, especially for a pediatric client, we may just defer it. And we're focusing on normalizing eating patterns, vital signs, what's going on there, physical exam findings, menstrual function, laboratory function, absence of eating disorder behaviors. And we want to keep in mind, what are the signs of nourishment? Because I think we can all get focused a lot on weight, which is an important piece because of that weight suppression research, but it's not everything. And so zooming out, knowing weight is a piece of this, but also looking at energy levels, menstruation, heart rate, blood pressure, appropriate time thinking about food. I know when my clients are renourished, they're spending a lot less time thinking about food, thinking about their body, that so often body image struggles improve with nourishment. Are they able to sleep now? Being malnourished wakes us up, so we'll go eat. So has sleep improved? How's the GI function? We know that our GI tract does not work well when we're malnourished. What's the health of our skin and nails? Have abnormal labs resolved? Although so often labs are normal all the way through. So we don't want to hang our hat on that too much. Has there been a decrease of eating disorder behaviors? Are hunger and fullness cues coming back? That can take a while. I do want to say that, but have they? And is this client able to interact socially? So I've got two case vignettes I'm going to try to run through quickly, just so we can do a few questions at the end. But this client's a 10-year, 4-month-old client that presented after eating more healthfully. Her parents, this person has always been a picky eater. She was pre-puberty. There was no findings on her EKG. All labs were normal. And she had always tracked between the 25th and 50th percentile. Growth charts were pretty predictable. Always tracked between the 20th, 50th percentile weight for age. Always tracked around the 10th percentile. For height for age, there was a little jump in the last few years. And then you can see there had been a 6.6 pound weight loss in 16 months. So these were the growth charts that were presented. So you can see between 9 and 11, this downward trend that was concerning. Height, pretty predictable tracking, but it kind of started going up a little bit, which we would expect weight to even go up a little bit higher percentile wise because the height had, but we saw this decrease. And so when I'm establishing expected body weight, I'm wanting 6 months from now, this child to be back between the 25th and 50th percentile. So I'm looking ahead on the growth charts and I'm determining what that might be. And so you can kind of see, currently she was 8.4 percentile, and to be 6 months from now between the 20th and 50th percentile, 71 to 80 pounds. And then 6 months from then, 75 to 85 pounds, 6 months from then, 79 to 90. And that's to stay at this minimum of where she had been pre-eating disorder. And I compared to the BMI chart, I'm going to run through this just so we can get to the adult and to our questions. So here's a 34-year-old female presented with a 60-pound weight loss in 9 months. Her current weight is 153. She heard from a lot of doctors she needed to lose weight. Her periods had stopped. She has had one child. She said she never had lost the baby weight. She had started intermittent fasting about 9 months ago. No prior eating disorder, but lots of dieting. Parent has a history of substance abuse, which is a risk factor for developing an eating disorder, to have a first-degree relative with a substance abuse history. She's had trouble sleeping, recent panic attacks. So we tried to, come up with a weight history. So her goal weight for herself was 150 because this would put her at a BMI of under 25, which is what the doctors had told her she needed to be. When she graduated from high school, she was 163. I'll say personally, most of the time I'm saying, well, we've got to be at least what you were when you graduated from high school. That our weight continues to increase post high school. And so genetically, this person is not supposed to be at a BMI of less than 25. At the end of college, she remembered she was about 168 and her pre-pregnancy was 175. Her period stopped at 165. So again, this is an estimate, shot in the dark. Let's get at least 170. Let's just at least at the very bare minimum. And then let's assess for these other things and work towards a renourishment. That may be too low, but let's see where this goes. And there we are. We made it through it. And I know we're close to our time, but I'm happy to answer a couple questions. And I'm going to show you that all the references are here at the end.
Thank you so much, Ms. Lutz. We will now go ahead and open up for Q&A. If you have any questions, we ask that you type those into the chat box. So I'll go ahead and start with the first question, Anna.
Okay.
When you catch a patient in your office who meets the risk criteria for refeeding syndrome and they can't get into a medical provider for a couple weeks, do you recommend they wait for start refeeding again until after they get assessed with labs from the medical provider?
That is a tough question, because we're weighing out risk of refeeding versus severe risk of malnutrition, and so it's such a nuanced question. I mean, I may be referring them to the ER to see if they can get labs through an emergency department, to not wait weeks. I wouldn't want to wait weeks for someone to start eating more, have more nutrition. If they're at severe high risk of refeeding, though, as a dietitian, I really do want them to have those labs done and a medical assessment. So it's a tricky question that I don't know if I have a great answer for, except to see if you can be creative of how the person can get labs.
Thank you so much for that response. I'll move on to the next question. Any specific recommendations for a woman recovering post-pregnancy with an eating disorder?
It's resources for someone, is that right?
Recommendations.
Any specific recommendations? I mean, I think, certainly someone who is pregnant or post-pregnant who has an eating disorder needs individualized care. I don't know of any specific resources out there except to find an eating disorder specialist who has experience working with pregnancy, because of course that's another complication of our body's needs pre and post pregnancy.
Thank you once again, Anna, for that. The next question reads, do you have a suggestion for calculations for transgender clients?
I'm not an expert in transgender care. I have attended webinars and trainings and learning as I go. And I don't believe there is consensus on certain calculations. I think it's really, from what I understand, is assessing individualized care of what makes the most sense for this person in front of you, of what calculations you're going to use. But that may, you may seek out a webinar specific eating disorder webinar on treating transgender individuals. I'm not sure if there's one through NSEED, but I can make other recommendations of those.
Thank you once again, Anna. As far as those recommendations, I'm not sure, but Folks are welcome to visit our resource library at www.ncdas.org in order to see if you find resources that match your particular inquiries. Anna, is there anything else that you'd like to share before we adjourn? I've addressed all of the questions we received thus far. If there are any questions that you may have at this time as an audience member, please feel free to put those in a Q&A box and I can get those over to Ms. Lutz and have them shared with you via email 1 week from today. As a reminder, we will also send the slides and the evaluation at the end of this webinar. Anna, do you have anything additional to share?
I don't think so. I appreciate being here today, and I appreciate the questions.
Well, thank you so much, Anna, for your time and this wonderful presentation today. We have 2 people, I think, that asked a question. Okay, they said thank you.
Thank you.
If you have any additional questions, feel free to send those to us and we'll make sure that those are shared with Ms. Lutz. We'll also put that information in the email that you receive with the slides at the end for contact if you have any additional questions. Thank you all for joining today. Thank you once again, Anna.
Thank you.
And you have a great day.